I had a patient once, and he told me, my wife and I spend so much money on arthritis medication and weed that we made a whole new bank account just for those two things. It's a joint account. Thank you so much. A man with arthritis goes to his local drug dealer. He says, "Man, I need a few new joints." Hi everybody, Dr. Ryan here again with another hard-hitting algorithm in internal medicine. This is going to be our first in this particular discipline. Now, I thought I wouldn't get around to doing this approach, but there's always room in rheumatology for an algorithm. I hope you and your family are well. Thank you so much for joining me and for liking and sharing my videos. Let's dig into arthritis today. So, arthritis describes inflammation involving any structure within a joint. Articular structures include the synovium, synovial fluid, articular cartilage, intra-articular ligaments, joint capsule, and juxta-articular bone. Mimics of arthritis include bursitis, tendinitis, enthesitis, epicondylitis, ligamentous damage, cellulitis, deep vein thrombosis, polymyalgia rheumatica, myositis, and periarticular bony lesions. Now, an articular process is suggested by the presence of pain with both active and passive range of motion. Note that, and joint line tenderness on palpation. To non-inflammatory versus inflammatory etiologies, the cardinal signs of inflammation include erythema, warmth, pain, and swelling. Right, and note the inflammatory variety also comes with early morning stiffness, at least above 30 minutes. Other inflammatory musculoskeletal conditions such as tenus hannovaris, enthesitis, and dactylitis can occur with certain types of inflammatory arthritis. Now, synovial fluid white count or white cell count is the single most important laboratory test in the evaluation of inflammatory arthritis. So in general, white cell count above 2,000 cells per microliter is consistent with that of inflammatory arthritis. Now, the most common causes of non-inflammatory arthritis include osteoarthritis and trauma. So those are number 1 and 2 up there. Inflammatory arthritis can occur in one joint, making it monoarticular, in 2 to 4 joints, making it oligoarticular, or more than 4 joint pattern, which is polyarticular. And inflammatory arthricities can generally be classified by the number of joints involved, but exceptions do occur, like with monoarticular peripheral spondyloarthropathies and polyarticular gout. So let's sink our teeth into this one. We said non-inflammatory versus inflammatory, right? And non-inflammatory, the two most common poster children, if you will, are osteoarthritis and trauma. Then, of course, hemarthrosis. Watch out for this in things like von Willebrand's disease and where there's clotting issues, okay? Charcot's joint, usually in the setting of diabetic neuropathy or even TB dorsalis, osteonecrosis of the joint, hypertrophic pulmonary osteoarthropathy, episodic arthritis of cystic fibrosis, watch out, acromegaly, and hemochromatosis, right? 9 causes of non-inflammatory arthritides. Inflammatory, we said, is monoarticular, which is 1 joint, oligoarticular, which is 1 to 4 joints, polyarticular, more than 4 joints. Now here, under monoarticular, we speak to crystal arthropathy. Usually what comes to mind is gout versus pseudogout, and how you diagnose that. You do a, arthrocentesis and send the synovial fluid off. And under polarized light microscopy, you look for the characteristics of the crystals. Is it rhomboid shaped or is it needle shaped? Is it positively or negatively birefringent? And then we get gout or pseudogout, right? Infectious acute, the classic example there is gonococcal monoarthritis. Then you get chronic infectious monoarticular, classic example being TB. Or monoarticular arthritis can simply be the first manifestation of early oligoarthritis. So we're going over to oligoarticular causes. Once again, disseminated gonorrhea is there. Steronegative spondyloarthropathies, where we're speaking to psoriatic, enteropathic, which is IBD associated, ankylosing spondylitis, and rheumatoid, which is reactive arthritis, right? You know those things right there. Spirochetal infection, Lofgren syndrome, which is indicative of sarcoidosis, electron-line purpura, cryoglobulinemia, which is associated with hepatitis C. We'll be talking about cryoglobulinemia in our next algorithm on the vasculitides, all right? Behçet's disease, right? Watch out for this oral and genital ulcers there. Early polyarthritis, right? So oligoarticular can be the first manifestation of early polyarthritis. We're looking at polyarticular etiologies. Here we're looking at more familiar terms: rheumatoid arthritis, systemic lupus erythematosus, viral infections, poly versus dermatomyositis, Still's disease, rheumatic fever, serum sickness, sarcoidosis. Let's dig more into the 2010 ACR-EULAR criteria for rheumatoid arthritis. Remember, this occurs in patients who have at least one joint with definitive synovitis, which speaks to swelling, and with the synovitis not better explained by another disease process. A cumulative score of more than 6 out of 10 classifies a patient as having definite RA. We're looking at 4 domains, right? Joint distribution, serology, symptom duration, acute phase reactance. Joint distribution, serology, symptom duration, acute phase reactance. Right? Let's speak to joint distribution. If you have just one large joint involved, it's 0. Because you know RA loves the small joints, right? If you have 2 to 10 large joints, you get 1 point, 1 to 3 small joints, 2 points, 4 to 10 small joints, 3 points, more than 10 joints, 5 points. Note there's no 4 here, right? It's 0, 1, 2, 3, 5. Boom. Serology, we speak to the either rheumatoid factor and or anti-citrullinated anticyclic citrullinated peptide antibodies, ACPA. If both are negative, you get 0. If you got a low positive value of either one, you get 2. If you got high positive RF or high positive ACPA, that gives you a whopping 3. How long have you had the symptoms for, my friend? If it's less than 6 weeks, it gives you 0. If it's more than 6 weeks, you get 1. Then, of course, we speak to acute phase reactants, looking at the CRP, which is C-reactive protein, and the erythrocyte sedimentation rate. If both are normal, you get 0. Abnormalities in either one gives you 1. Definitively, rheumatoid arthritis, if your cumulative score is 6 or more. Got it. Looking at the 2019 ACR EULA classification for SLE, which is actually, this is also what conforms to the SLIC criteria, right? Systemic Lupus Erythematosus International Corroborating Clinic SLIC criteria. So the entry criterion is anti-nuclear antibodies that are titers of greater than 1:80 on HIP2 cells or equivalent positive tests, right? If absent, we can't say this is SLE. If present, we have to apply the additive criteria. All right, a cumulative score of greater than 10 with at least one clinical criterion means, my friend, that you have SLE. Okay, so here we speak to immunological domains and the clinical domains, all right? So clinical domains, you score according to the features mentioned, right? Constitutional, so if you get fever, you get 2. Hematological, look at leukopenia, you get 3, of which lymphopenia is usually the order of the day. Thrombocytopenia, you get 4. Autoimmune hemolysis, you get 4. And how do you know you're having autoimmune hemolysis? Well, your hemoglobin will be low, right? Because that's anemia. Then you're going to have hemolysis. Your lactate dehydrogenase, LDH will be up. Your indirect bilirubin may be up. Haptoglobin is going to be low, all right? And also, if it's autoimmune, you know that your Crohn's is going to be positive and your reticulocyte production index will be high because the bone marrow is trying to catch up and trying to churn out extra red blood cells, making your RPI high. All right, got it. Neuropsychiatric manifestations, delirium, you can score 2 points, psychosis 3 points, seizures 5 points, mucocutaneous, all right. So here we speak to acute versus subacute versus chronic cutaneous lupus. So the acute cutaneous lupus is 6, and this usually speaks to the malar rash, the photosensitivity, the non-scarring alopecia, the oral ulcers, all right. Subacute cutaneous, we're speaking to the so-called annular or polycyclic versus the psoriasiform lesions, and the chronic cutaneous is discoid lupus together with paniculatus and lupus tinnitus and so forth, right? Serosal, we're speaking to pleural pericardial effusion, gets you a whopping 5. Acute pericarditis gets you a nice 6. Musculoskeletal involvement, joint involvement gives you 6, usually in the setting of polyarthralgia, polyarthritis. Renal, we got proteinuria, 1 shot. If it's more than 0.5 grams per 24 hours, it gives you 4. Or a urine PCR, which is greater than 0.05, which is the same as saying 500 milligrams or 0.5 grams on a formal 24-hour urine PCR. A renal biopsy class 2 or 5 according to the WHO classification, you get 8 points. If it's renal biopsy class 3 or 4, you get 10 points, right? All right. Let's talk about the serology quickly, right? Antiphospholipid antibodies, anticardiolipin, or anti-beta-glycoprotein 1, or lupus anticoagulant gives you a whopping 2. Complement proteins, if you've got low C3 or low C4, you get 3. Low C3 and low C4 gives you 4. SLE specific antibodies, if you've got anti-double-strand DNA or anti-Smith positive, it gives you 6. Remember, a cumulative score of 10 or more means that you have SLE, or if you have a biopsy-proven lupus nephritis class 5 with some antibodies. All right. 2013 ACR EULA criteria for systemic sclerosis. Sorry about the typo there. If you get a cumulative score of over 9, it means that you have systemic sclerosis. So skin thickening of the fingers of both hands proximal to MCPs gives you 9 points, right? Skin thickening of the fingers only, which means you have puffer digits, gives you 2. Fingertip lesions, where we speak to digital ulcers with 2. Fingertip scars with 3. Telangiectasia 2. Remember the pulmonary hypertension and or interstitial lung disease, all right? That happens. Remember that the more limited systemic sclerosis means that usually is associated with pulmonary hypertension versus the diffuse systemic sclerosis, which gives you more ILD. But those are not all-encompassing and all-inclusive. It's not hard and fast, but usually suggestive, right? 2 for each of those. Renals, you get 3. Systemic sclerosis-related antibodies, where we speak to the anti-centromere, anti-scleroderma 70, or RNA polymerase, you get 3. Okay, cumulative score more than 9, systemic sclerosis. Good stuff, good stuff. This is medcomic.com, right? Beautiful. Thank you, Mr. George Muniz. telling us about ankylosing spondylitis. Quite fun. Seronegative spondyloarthropathy characterized by back pain and stiffness of the spine. We know this, right? HLA-P27. Right, this speaks to the genotype associated with ankspond and basically with all your seronegative spondyloarthropathies. Features, of course, uveitis. See the guy with red eyes here. This guy's heart is coming out of his chest. Speaks to cardiac abnormalities, usually aortic fluid dilatation, predisposing to aortic regurgitation. Pulmonary disease in the way of apical fibrosis. See this guy's coughing. This is the panda bear. His name is Schober. Interesting, because modified Schober test is one way or one provocative test we use to diagnose sacroiliitis. Okay, not really sacroiliitis, but limited lumbar flexion, speaking to ankspond. Okay, bamboo spine here, which is a characteristic radiographic feature of ankspond, with the characteristics in desmophytes or squaring of the vertebrae. Sacroiliitis is dart going into close to his bum, speaking to sacroiliitis. Right? Non-steroids are first-line treatment. Fun stuff. Crest syndrome, as we know, speaks to limited cutaneous systemic sclerosis, the typical features, where we have calcinosis cutis, right? So you've got these little popcorn looking lesions here. Reynolds phenomenon, the chap is looking at his hands, his fingers. Esophageal dysmotility, you can see a hot dog sitting in the esophagus. Sclerodactyly with these funny type of fingers. Telangiectasia with a typical rash, okay? Polymyositis versus dermatomyositis. So both are inflammatory myopathies with progressive symmetrical proximal muscle weakness. All right, both of causing, we speak to chairs, hairs, and there's one more that we speak of, which speaks of proximal muscle weakness. People have difficulty arising from a seated position, difficulty combing their hair, difficulty hanging up, washing, and so forth, right? So with dermatomyositis, typical rash, we get a heliotrope rash, which, why is it called heliotrope? Because it's a violaceous rash, which looks like the heliotrope flower. Mechanic's hands, Gottron sign, Charles sign as well. Then if you do a muscle biopsy, which is the way you definitively diagnose polymyositis, you will see a cytotoxic CD8 cell predominance and anti-Jo1 antibodies on serology. Okay, to keep things fresh and exciting, a beautiful OSCE question from the Mayo Clinic. Let's go. A 34-year-old woman complains of daily fevers, evanescent rash. Now, not the rock band Evanescent. You know that song, My Immortal, I think it was called. No. You're speaking to the rash here, okay? Let's focus. And arthritis. Rheumatoid factor, anti-nuclear antibody, and Lyme serology are negative. The ferritin value is a whopping 1,200 microgram per liter. Why is the most likely diagnosis? Here we can appreciate the evanescent rash. Here I think they're just showing us some cyanovirus. Sorry, it doesn't project very well. Okay, I'll be looking at infective endocarditis, adult onset stills, Bancroftian fever, relapsing fever, quotidian fever. Well, the answer here is actually B. Sorry, I didn't highlight this nicely, but the answer is B, adult onset stills disease. So this disease was actually first described by a guy called Watsup in 1971. The pathogenesis is unknown. Multiple diagnostic criteria exist, but Yamaguchi's criteria have more than 92% sensitivity across multiple population groups. So here we speak to major and minor criteria. So the major criteria being fever, arthralgia, typical rash, and leukocytosis. The minor criteria being a sore throat, lymphadenopathy, splenomegaly, liver dysfunction, and absence of rheumatoid factor and anti-nuclear antibody. Diagnosis is established if 5 or more criteria are present, including 2 or more major criteria. So the rash is often described as evanescent and maculopapular or of salmon pink coloration. The arthritis is most common in the wrists, shoulders, hips, knees. Patients may also have serositis. Watch out. Okay, although not part of the diagnostic criteria, the ferritin value is characteristically increased. Hello, 1,200 microgram per liter, guys, in this question. And this serves as a marker of active disease. Infectious, malignant, and other rheum diseases should be excluded. Treatment is with our infamous non-steroidal anti-inflammatory antibodies. Okay, guys, so sorry, man, this video is a bit longer than what I usually put out, but rheumatology is quite extensive, right? It's impossible to cover the length and the breadth of rheumatology in just a few moments. But as always, it's something to just encourage you from the Bible. Psalm chapter 23 is a psalm of David. The Lord is my shepherd, I shall not be in want. He makes me lie down in green pastures. He leads me beside quiet waters. He restores my soul. He guides me in paths of righteousness for his name's sake. Yea, even though I walk through the valley of the shadow of death, I will fear no evil, for you are with me. Your rod and your staff, they comfort me. You prepare a table before me in the presence of my enemies. You anoint my head with oil. My cup overflows. Surely goodness and love will follow me all the days of my life, and I will dwell in the house of the Lord forever. Amen. The Lord is our protector, our provider, our sustainer, our intercessor, our mediator. He is our healer. He is our God and our master, and there's no one like him. So I hope today that you've been encouraged and you have been edified through this algorithm. I will see you tomorrow with our next algorithm in rheumatology. See you then. Okay, bye.